That's not only bring it back down.
He would drive so slow. Somebody hit the core. First he stopped, and then he stopped. He just kept
Is 7 a.m. to 6 a.m.?
That's my motto. It's not bad.
What? Yeah.
Usually it's questions. Students, I think it might have been. Oh. That might just help.
Thank you so much for that.
What parent treatments for all these different things?
Everything they say, it's like 50% of the time.
How do you pronounce that word?
Hyper-CKemia.
Well, it's a challenge.
That's some very bad connotations in Turkish.
Okay, I think I'm going to go ahead and begin. Good morning, everyone. So, my talk today is approach to patients with elevated CK levels or hyper-CKemia. So, CK determinations are tests we commonly use in neuromuscular medicine. They're extremely useful and inexpensive. And we use them to evaluate patients with suspected myopathy. So my talk will focus on how we evaluate these patients for a specific diagnosis, and I will also give some case examples. So CK is a small enzyme, roughly 86 kilodaltons, whose function is to combine creatinine and ATP to form phosphocreatine and ADP. So it's really a crucial reaction for cellular energy generation and also metabolism. So it's function as a temporal energy buffer, so it's activated as one of the first sources for energy in the muscle tissue with exercise. And it's also site of high energy production and consumption, so it's largely present in the cytosol of the muscle fiber and to a smaller extent in the mitochondria. So it's present in 3 isoenzymes. MF is the one that is predominantly present in the skeletal muscle in about up to like 99%. And MB is present in cardiac muscle, and BB is present in the brain. And when we measure the serum CK level, we are measuring the sum of all these 3 isoenzymes. In case of muscle injury, due to its relatively small size, there's and really an easy leakage out of this enzyme out of the ischemic muscle tissue. So a precise definition of what hyper-CKemia is or elevated CK level is, it's kind of controversial still at this point because there is disagreement as to how high the levels should be in order to raise concern for an underlying disease. In most clinical settings, the normal levels are portrayed as the reference range provided by the laboratory. And in our institution, this range is 149 to 394 units per liter. So we know that several factors can influence the level of the enzyme. And this is primarily race, age, and gender. Several studies have shown that Africans have slightly higher levels of the enzyme, and it can correlate with the muscle mass also. And muscle activity can also directly influence the level of the CK level in the serum. So several groups have looked into what the normal range is based on specific gender and race factors, and they've discovered that these numbers, the mean CK levels, come from an older study done in 1980s, but a repeat study later on in 2007 confirmed the same similar CK levels in these 3 groups. So they identified 3 groups One was a high CK level consisting of black males with a mean CK level of 337, and an intermediate group formed by non-black males and black females with a mean CK level ranging from 110 to 150. And a low CK group consisting of non-black females with the mean range again in the 60s to 80s. So it tells you that females have this, tend to have a lower level of CK, and if you are black and have are muscular, you are likely to have a high CK level compared to the rest of the population. So the second group suggested that the laboratory studies should actually consider the pathological level if the level is higher than 97.5 percentile, and suggested that there should be an upward adjustment of these levels. And it has taken place, I think, in certain laboratories. But there's also a concern that it can reduce the sensitivity of the test. So, and another concern about when we deal with high CK levels is, could there be really a systemic disease which can explain this level? And we certainly consider many diseases which secondarily cause myopathy, and in these cases, it's really not a primary muscle disease, but a secondary involvement of the muscle explaining the high CK levels. Some examples are connective tissue disorders. We know that they can cause myositis and therefore increase the CK levels. Some endocrine diseases like hyperthyroidism, hypothyroidism, or hypoparathyroidism, which can also lead to damage of the muscle fibers. And metabolic disturbances like hyponatremia, hypokalemia, and hypophosphatemia can also lead to myofiber damage. And we know that muscle trauma, like intramuscular injections, needle electromyography, seizures, and pregnancy can transiently elevate the CK levels. But I think most importantly in this group, the most important etiology we need to consider in every patient presenting with high CK level is a drug's toxic effect of certain medications. And I'm going to list these medications in a separate slide. So perhaps the most well-known class of medications causing high CK level is the statins. So they reduce, they inhibit this enzyme and reduce the production of cholesterol. And they have been shown in multiple studies to cause a range of symptoms. Could be myalgias, could be obvious myopathy, and even rhabdomyolysis. It's really not clear how these medications induce this whole range of symptoms, but there are several suggestions. And one is that it can really, a reduced level of cholesterol may damage the muscle membrane. And there's also some suggestions that maybe there's some mitochondrial dysfunction, mitochondrial abnormalities leading to muscle fiber damage. And more recently, one study suggested that patients who have myopathy while on statin medications can also have some metabolic occult, like latent metabolic problems. So there could be maybe some genetic factors in play as well. But what we know is that if you are taking a high dose of statins, if you're combining it with fibrates and some other drugs that interfere with elimination of statins, the risk is much higher. The estimate or incidence of the myopathies on patients, in patients taking statin medications, ranges from 1 to 5%, but this could be a higher incidence because most of the time, when it's reported a CK level elevation, more than 10 times is reported in the clinical trial. So potentially, this incidence is much higher. Other medicines that can cause a high CK level are beta blockers, ACE inhibitors, hydrochloroquine, and isotretinoin, which is formerly known as Accutane. And some drugs of abuse, like cocaine and heroin and ethanol, can also induce high CK levels. So a transient rise in CK levels can also be observed in normal individuals, especially after an unaccustomed exercise or heavy manual labor. So we know that if the exercise is particularly strenuous or exceeds customary levels, patients can develop symptoms of muscle soreness, weakness, and even myoglobin in very severe cases. And when it occurs within 24 hours after the exercise. So CK levels may rise as high as 30 times of upper limit of normal, and then they slowly decline over a course of 7 to 10 days. And even in asymptomatic individuals, after a strenuous heavy exercise, CK levels can go above 10-fold above of the normal or upper level limit of normal. So the degree of CK elevation tends to be more pronounced in untrained individuals. This is also called the couch potato syndrome. So if you're really not doing regular exercises and you go on to do some intense exercise, your levels actually will definitely increase. So since most persistent elevations in CK levels are associated with myopathies, several investigators looked into if there's a correlation between the degree of the elevation and a specific form of myopathy. And this study is from Dr. Lacomas from University of Pittsburgh. So what he tried to identify, if this will help us to lead to a specific diagnosis. But unfortunately, the only strong association between a CK level and the specific form of myopathy is present in dystrophin deficiencies or dystrophinopathies. In Duchenne and Becker muscular dystrophy, the CK levels can go up as high as 100-fold of upper limit of normal, and it can also go up to more than 10-folds in other forms of muscular dystrophy like limb-girdle and Emery Dreifuss. And among the acquired causes of myopathy, the highest CK elevation is really present in the inflammatory myopathy group, the polymyositis and dermatomyositis. Unfortunately, for the rest of the myopathies listed in this slide, there's really not a good correlation between CK level and specific form of myopathy. So therefore, I would like to give you a review on how we approach patients with high CK levels based on the clinical history and to a smaller extent the examination. So I can not emphasize enough that history taking is really a big part of reaching a diagnosis in neurology. And most of the time, if you do a good history taking, you can divide patients between acquired and hereditary causes at the end of your history taking. But there is some recommendation as to what specific questions to be asked to these patients. And I will give you the 6 most important questions that we need to ask in patients, to patients with high CK levels. So one of the first questions is, what are the symptoms? Are there positive symptoms or negative symptoms? And if there are symptoms consistent with myopathy, what's the temporal evolution? What's the age of onset? Is there a family history of neuropathy that will actually support an inherited form of neuropathy? And are there some other associated systemic symptoms or signs which can also help narrow the differential diagnosis? And from the examination, the distribution of weakness will also help you in reaching a specific diagnosis. And one other important question is, are there any precipitating factors that trigger the weakness or stiffness in an episodic fashion? So this approach is called the pattern recognition approach. It's recommended by 2 famous neuromuscular physicians, Dr. Jackson and Dr. Barron, and their articles are published in one of the recent continuums, so I'm going to use a lot of their tables. So the symptoms that are associated with myopathies are divided into the negative symptoms, the most common of which is the weakness. and also fatigue, muscle atrophy, and exercise intolerance. The positive symptoms include muscle cramps, contractures, myalgias, myoglobinuria, stiffness, and hypertrophy of the muscles. So the most common pattern of weakness that you see in myopathies are proximal weaknesses. Patients will, report symptoms related to proximal weakness in the legs, such as difficulty climbing stairs, difficulty rising from a low-seated chair, or difficulty rising from a squatted position. If the weakness is in the upper extremity proximal muscles, they will complain of difficulty lifting up objects, brushing their teeth, or combing their hair. And there could be some distal weaknesses also associated with certain forms of myopathies, but it's much less common. And some cranial neuropathies, bulbar weakness, you can also see in a small group of patients with myopathies. Fatigue is another negative symptom that can be reported by patients with myopathy. However, it's very nonspecific, and it commonly occurs as a result of patients' overall health, maybe cardiorespiratory status, sleep problems, or level of conditioning. Actually, a lot of patients who report generalized weakness, fatigue, with a normal exam are unlikely to have a myopathic process. Now, exercise intolerance is commonly reported in metabolic myopathies and also to some extent in mitochondrial myopathies. So, but it's always important to define the duration and intensity of the exercise when you're questioning them. The positive symptoms include muscle cramps. Cramps is again another nonspecific symptom and are not very commonly associated with myopathies. They are most likely associated with a neurogenic problem, actually. So they can also occur secondary to dehydration, some of the electrolyte disturbances, hypothyroidism, myxedema. So these disorders should also be investigated. In case of myalgia, again, it's a non-specific symptom, and you should first look for some rheumatological or orthopedic causes, especially if the examination, neuromuscular examination is normal. And contractures are similar to muscle cramps in the sense that they are painful. They're most likely induced with exercise. However, the difference between the cramps and contractures is that cramps are electrically active. So if you put a needle into the muscle, cramped muscle, you'll see rapid firing motor units. In contractures, you will not see that. They're actually electrically silent, and they're more likely to be associated with metabolic myopathy. So it's a more significant symptom that you can actually try to elicit from the history. And muscle hypertrophy can be seen in certain forms of myopathy, such as muscular dystrophy, actually pseudohypertrophy in Duchenne and Becker due to replacement of the muscle tissue with fat and connective tissue. You can see muscle hypertrophy in myotonia congenita, and sometimes you can see in some denervating processes as well due to partial denervation. And myoglobinuria is release of myoglobin from the muscle tissue into the blood, and it's actually a sign of rhabdomyolysis most of the time, or a sign of metabolic myopathies in which there's muscle damage and then it's released into the blood. So it could be helpful to confirm that patient has a metabolic myopathy if you are able to confirm that. It's always good to ask the patient if their actually urine color change after exercise. Does it turn red or reddish or brownish after exercise? It's a good way of determining if they could have myoglobinuria. And muscle stiffness, this could represent myotonia. Myotonia is inability to relax muscles due to repetitive depolarization, and you see that in certain forms of processes such as myotonic dystrophy, and there are a few non-dystrophic myotonia cases that you can also see who would complain of stiffness distal, mostly in the distal muscles, locking of the hands, and they can also complain of worsening symptoms in cold temperatures. So after obtaining this history on the symptoms, we can determine the onset, age of onset of the myopathy and the temporal evolution of the disease. So you can imagine that it's really very important to determine if the age of onset is at birth in the first or second decade of life, because then you will consider the inherited form of myopathies. If the presentation is really since birth, you will consider the congenital myopathies, congenital muscular dystrophies, and also some of the metabolic myopathies such as acid maltase deficiency and carnitine deficiency. If the onset is in childhood, in the appropriate setting, of course, Duchenne muscular dystrophy should be considered. But you can also see some acquired causes starting in early childhood, such as dermatomyositis, and some endocrine disorders can also present in this period. If it's adult onset disease, then the differential is broad. And at that point, the evolution of symptoms can help you to determine if it's an acquired problem. So in case of an acute or subacute onset, you'll consider an inflammatory myopathy as the most likely etiology. And your goal as a clinician is always to look for treatable causes of myopathy, so you'll consider these diagnoses that I'm listing here. And if it's a very slowly progressive course, then you'll consider inherited forms and muscular dystrophies. If there's not much progression over decades, then you may consider even the congenital myopathies presenting in early adulthood as the potential etiology of the CK elevation. So another approach is to obtain a good family history so you can determine the inheritance pattern. I know you recently listened to a talk on muscular dystrophy, so I'm not going to dwell into this too much. But a careful history, it will help you to determine if it's a dominantly inherited disease, recessively inherited disease, or if only the males are involved, maybe an X-linked disease. And so you will have to even require about not just muscle disease, but family members who had functional limitations, because that might be more informative for you than asking specifically for muscle disease. And you can ask if they actually, any family members were using assistive devices for walking or any mobility devices, and that might also provide some information to you. And associated signs are also helpful in determining or narrowing down the differential diagnosis, since I'm showing you 10 different diagnoses in each and every table. So if a bunch of muscular dystrophies can present with respiratory insufficiency, but you can also see that in polymyositis rarely. So rare reports of polymyositis, which can present as respiratory insufficiency during the early stages of the disease. But if it's really the initial presentation, you would consider acid maltase deficiency, central nuclear myopathy, acid maltase deficiency, and amyloid myopathy are most likely etiologies. And then another group of myopathies which can also cause cardiac disease is listed here. And you'll see that, you can see that in some of the acquired, but mostly in the inherited forms of the myopathies. And the last question to ask is if there are any triggers for episodic pain and weakness and or myoglobinuria. And so I already mentioned to you that if the patients are unaccustomed to have exercise, if they have a very intense activity, physical activity, they can actually, you can see that they can have rhabdomyolysis even. But if it's a recurrent problem, if the patients are having recurrent rhabdomyolysis, then you will consider metabolic diseases like glycogenosis and lipid disorders. If the symptoms are not related to exercise, then you'll think of causes like status epilepticus, neuroleptic malignant syndrome, drugs, toxins, malignant hyperthermia, and rarely the inflammatory myopathies. And now I'm going to switch gears a little bit and present a case which is related to this slide that I'm showing you, a patient who had episodic weakness and pain. So I saw this patient about 2 years ago. He was referred to me by a nephrologist in Mountain Home. And because he had actually repeated weakness with high CK levels, diagnosed with rhabdomyolysis. So a 36-year-old left-handed white police officer presents with exertional cramps and weakness of lifelong duration. So he basically had these symptoms all his life, and he was never a good athlete. So any activity that required any intense activity for brief duration, or even low level of intense activity for him, was impossible to do. So after each and every one of these episodes, he would actually experience weakness for about 2 to 3 days. He achieved his milestones on time, but as I said, he was never muscular and was never able to keep up with his peers in sports. He could not join military due to inability to run and lift weights. However, he was able to become a police officer, but he had some trouble at work, and so that's why he was referred to us. Initial episode of rhabdomyolysis was 4 years prior to his presentation, and a second episode occurred recently at the time for another episode in which he had to just chase a suspect and run for a little bit, and then he became extremely weak after that. And his CK level was found to be in the range of 17,000. He denied any family history of similar problems and any illicit drug use at the time. So his kidney function recovered pretty nicely from both of these episodes, but he was hospitalized for both of them. On examination, he had reduced muscle bulk of the shoulder girdle muscles, but really no scapular winging or not anything significant. And his examination didn't really show any abnormal strength, so he had actually 5 out of 5 strength throughout. And his reflexes were absent diffusely, but he did not have any other cranial nerve sensory, cerebellar, or gait abnormalities.
How severe were the episodes that triggered his rhabdo?
So he would describe like 5 to 10 minutes of high intensity exercise. So it's really a short duration. So,
But did the police department change their recruiting strategy?
well, initially I think he didn't want, like he knew that there was something wrong with him, but I think he didn't really want it to be known, so he didn't use, but he couldn't keep up with the work.
I think a physical fitness test should be part of any kind of police academy admission requirement. You know? I mean, as a referee, as an old guy, you have to do physical fitness. You have to run.
So when I saw him in clinic, which was about 3 months after his most recent rhabdomyolysis, his CK level was still quite elevated in the range of 7,000. He couldn't tolerate an EMG study. He just couldn't do it. So we stopped it, after nerve conduction studies, which was pretty much normal. So we proceeded with a muscle biopsy. But the initial evaluation on the biopsy was negative. So at this point, I want to ask the audience what the thoughts are, if anyone who wants to take a guess.
Did that include enzyme stains on the muscle biopsy?
No,
or just
it did
HLA?
not.
Okay.
So the initial, the usual stains, the routine stains was not.
This is most likely a metabolic myopathy being like so much.
Yeah, so if you're a fan of Dr. House, you can imagine him saying that, give me a walk and figure that out. I think you can do it probably sooner than that. So he had a metabolic form, but which one?
That's most likely the most common form is a glycogen storage disease, most likely acid maltase deficiency.
Acid maltase.
Yeah. So because it says so far, because the most common form, if I'm taking a guess.
It's unlikely to be acid maltase because he doesn't have any weakness on examination, so they typically have some constant weakness on examination. But it's a good thought. So we actually, I'm going to briefly review rhabdomyolysis. Yes.
Yeah, so I would be thinking about things that are cause problems with increased energy use, so CPT deficiency, adenosine deaminase deficiency, those kinds of enzyme problems.
Absolutely. So that's really your approach should be. So rhabdomyolysis is severe necrosis of the muscle, which leads to release of these intramuscular, intracellular constituents into the circulation, most commonly CK, followed by myoglobin and other enzymes. So CK levels are typically elevated above 10,000 range. And the range of disease could be like asymptomatic CK elevation to life-threatening disease due to electrolyte imbalances or acute kidney injury. And the most commonly identified mechanism is really the increase in the intracellular or intramuscular calcium levels. So there could be various initiating events like hypoxia, some electrolyte disturbances, or some metabolic problems. But it's believed that these lead to the energy depletion, the ATP depletion in the muscle, and this also secondarily causes the increased calcium levels, which then activates all these proteases and then leads to muscle fiber necrosis. But the common pathway is really the calcium deposition in the muscle tissue. So there are multiple causes of rhabdomyolysis. And this picture is to show you how diffuse the muscle necrosis can be, leading to the CK elevation. On the right side, so you see the diffuse necrosis of the muscle fibers, and left is actually a normal muscle tissue stained with H&E. So roughly, we can classify the causes of rhabdo to traumatic causes, non-traumatic causes. Non-traumatic ones can be exertional or non-exertional. Probably the most common cause is the traumatic causes, followed by drugs and toxins. So the incidences vary between studies, but I think you should always consider muscle trauma, crush injuries, immobilization, coma, and some surgeries as the cause of rhabdomyolysis if the story is not especially recurrent. Again, if it's really recurrent rhabdohistory, you'll consider the metabolic problems of the muscle tissue. And this slide lists you the different problems. So it could be a disorder affecting the glycogen breakdown in the muscle tissue, or glucose utilization in the muscle tissue, or fatty acid utilization in the muscle tissue. So these are the three energy sources for the muscle, and a problem in each and every step of these metabolic pathways can actually lead to rhabdomyolysis. One study found they studied 77 cases of recurrent rhabdomyolysis and discovered that actually CP2 deficiency was more common in frequency compared to McArdle disease, but those were the two major diagnoses that came out of that study. So what we did in our patient is we tried to get the myophosphorylase stain, but it was indeterminate basically. Initial report said that they couldn't determine it, they're going to repeat it. Repeat study said maybe weak, but we're not sure. So then we decided to send the muscle tissue for biochemical analysis, and they discovered basically no level of the enzyme, confirming that it's McArdle disease. Patient didn't want to get any genetic studies done, and he decided that he's going to retire or quit his job. So, although actually in these cases, a moderate degree of exercise is recommended, but strenuous exercise is really not recommended. So we were hoping to see the deficiency of the enzyme in the muscle tissue, but that did not take place, so we had to send it for biochemical studies. So on the right, again, you see a normal histochemical stain of myophosphorylase, and on the left, the patient who's deficient in So it could be a helpful way of diagnosing the disease, but I guess if it's normal and if your suspicion is very high, you still can proceed with some specialized testing like the biochemical studies or even a forearm exercise test. So it's a disease caused by the mutation in the chromosome 11. So there's only a single form of human phosphorylase, and so it's mapped to this chromosome, and there are several mutations that can lead to deficiency of the enzyme. So glycogen cannot be cleaved, glucose 1-phosphate cannot be produced in the muscle tissue. So there's all these symptoms of recurrent exercise-induced weakness, myalgias, and muscle cramps. So typical age of onset is really early childhood, but could be up to 50 years of age. And it's slightly predominant in males. The most common symptom is exercise intolerance and myoglobinuria and recurrent rhabdomyolysis. Some patients, actually up to 50% of patients described persistent muscle discomfort and cramps. And if the weakness is present in a small percentage of patients, it could be a fixed weakness, but it's really not very common in this disorder to have significant weakness of proximal muscles. It tends to be mild if present, and muscle wasting can be seen in older patients involving the shoulder girdle muscle. In our case, there was slight atrophy of his proximal upper extremity muscles. A second wind phenomenon has been also described, meaning that after rest, these patients can go on, do some more exercise, and do not experience the symptoms. And this is attributed to potentially increased blood flow and utilization of the fatty acids in the muscle tissue. Treatment, there's really not good treatment, and so it's recommended that they actually go on high carbohydrate diets and then maybe even take some sucrose before muscle activity. So just a brief overview on this forearm exercise test. So it used to be an ischemic forearm exercise test, but due to reports of having focal rhabdomyolysis and compartment syndromes, it's eliminated from the procedure. So this is a study that you can use to confirm the presence of a metabolic abnormality in the muscle. What you do is basically you establish a venous excess in the arm, and then you make the patient exercise for a short duration, and then you measure the lactate and the ammonia peaks at certain intervals. So there should be a sharp increase in lactate level and a slower increase in ammonia level. This graph is from a patient reported many years ago in neurology as he developed compartment syndrome after the ischemic forearm exercise test. And you can see that the lactate level did not really rise and remain low after exercise. Typically, you expect about a 3-fold increase in muscle lactate level, but this didn't take place. So it confirms that likely, sorry, the arrows are off, but that likely the etiology is in the glycolytic pathway of the muscle. So now, in second case, which is on the other end of spectrum for hyper-CKemias. So this is a 46-year-old man referred for evaluation of myalgias and elevated CK levels. He complained of pain involving his thighs and calves after activities, but the pain actually persisted throughout his day. It's been ongoing for a long time, and it just worsened slightly with physical activity, but it really didn't prevent him from doing any of his routine activities. He actually worked in an environmental service section, and he did actually do quite a bit of physical activity throughout the day, but didn't have any trouble with that. He also didn't have a prior history of functional limitations. He was able to play sports and denied having any suggestion of myoglobinuria. But his CK levels were elevated. The highest level was 1200, and the most recent prior to his referral to our clinic was 517. There was again no family history, no other medical problems, or no medication used to explain a CK elevation. So on examination, a young, muscular African American man, his exam was completely normal, EMG was completely normal, and after a period of exercise, his CK level went down to 331. At the time, was still high for our lab, but we repeated this study after 7 days of rest, and his CK level came down. So what would you do in a patient like that? Refer to you because initially his CK level was high. Would you like to do any more workup? After listening to what I recommended, yes. So probably you will not do anything for this patient because, his examination is normal and his CK level came down to almost normal levels. So this case represents asymptomatic or post-symptomatic, or they call it oligosymptomatic CK elevation. It's an incidental finding of elevated CK levels as they are done for a routine workup for some vague symptoms like myalgias in this case to see if it could be from the muscle. And they found it, so what do? So they send a patient to neuromuscular clinics for further evaluation. In any patient who has this mild elevation of CK levels, you should look for all these systemic causes that I have already mentioned, and also muscle trauma and medication use, and exercise. So if they are exercising, you can tell them to abstain from it and have the repeat level done. And this will actually, if you have the level repeated, this will probably reduce the number of referrals to our clinics. So would you evaluate these patients for latent neuromuscular disease? To some extent, yes. And there are several studies who look into that, especially if the CK elevations were persistent. So, and they looked into potential causes of these latent diseases, who can just induce a mild elevation in the CK with almost normal examination, and they found that you can see a group of muscular dystrophies, a group of metabolic problems, and also even some inflammatory myopathies as the explanation, but these are very rare and just like few case reports of it. So the laboratory studies you need to perform before considering workup for neuromuscular disease include some of the things I already mentioned: electrolyte levels, thyroid dysfunction, vitamin D levels, HIV studies, urine analysis, looking for collagen vascular diseases. And if you feel like the patient doesn't have a good explanation, you can proceed with an EMG and even a muscle biopsy. So idiopathic hyper-CKemia describes patients with persistent elevation of CK despite normal neurological evaluations. And it was introduced, the term was introduced in the 1980s, and for these patients who do not have any abnormalities. So, but they discovered that in a group of these patients, they found basically female carriers of dystrophinopathies. So it became a part of the criteria that you actually will look for possible carriers of dystrophinopathies, and these could be the females on the paternal side or mothers of patients who have children with muscular dystrophies. And there was one study which suggested that maybe it's a familial trait. They discovered that 13 families, and in these 13 families, 41 individuals had CK elevation, and they said that maybe it's really, there's a genetic disposition behind that. The true incidence of it is really not known. There was one large scale study from Norway that suggested that it could be up to 5% of patients, they studied a population sample of 12,000 and discovered CK levels, but after elimination of all the medication use and these other diseases, that decided that it's really a very small incidence of high CK levels. So several studies looked into possible etiologies and the diagnostic value of performing EMGs. They do suggest that you do the EMG studies. It's a sensitive way of determining if there's a neuromuscular problem, not necessarily myopathy, but could be neurogenic disorders as well. The biggest group of patients was in this study from Italy. They looked at 100 patients and found abnormalities in about 57% of them. And all these patients in these studies also went on to have muscle biopsies. They did have abnormal muscle biopsies in up to 66%. However, most of these biopsies were not diagnostic. So when they actually looked at it in aggregate, they decided that the yield of a muscle biopsy is really about 23%, which is very low. And combining the data from the EMG, it looks like the likelihood of coming up with a diagnosis when the patients have idiopathic hyper-CKemia is about 28%. So the recommendations are that you don't really do much if the CK level is only mildly elevated. It's a crowded slide, so I'll take you through it. If the CK level is only mildly elevated, you don't do much and observe if the examination is normal. But if they do have exercise intolerance, you can search for metabolic diseases. If they do have a higher CK elevation, you can do an EMG to rule out rare causes and even proceed with muscle biopsy. And if they're abnormal, you can proceed even with genetic studies as I said, a certain number of dystrophies were found to be common, and these include caveolar mutations and a few other rare forms of muscular dystrophy. So prognosis is very good. In 2 studies that looked at these patients for about 7 years, only one had an unclassified limb-girdle muscular dystrophy, and in the second group, 65% did not have any change or did not develop any symptoms. So we think that it's really carries a good prognosis. However, rare cases of caveolin 3 mutations have been reported in these patients. So I guess if the patients have some abnormal studies like EMG and muscle biopsy, you may elect to follow these patients for development of some of these abnormal rare forms of muscular dystrophy. All right, so I'm going to stop here and take your questions. Yeah.
So in your second case, 46 years old, relatively minor symptoms, minor CK elevations. Would you put this guy on a statin?
Oh, good question. Well, with exercise caution, probably he's going to have myalgias and can develop myopathy. So you would probably tell him not to go on statins if he has a very high risk of cardiovascular disease. So it's a benefits-risk ratio. Again, you need to judge it based on this. But in a patient who has baseline elevations, very mild, you probably, and if they have hyperlipidemia, you will probably warn them that, the myalgias and they can develop myopathies. But if it has to be done, then I guess you can monitor the CK level in the patient and try it, attempt it. But the risk of having myopathy will probably be higher in this individual.
I have a question. So statins has been speculated that could be potentially risk factor according toward Alzheimer's and ALS. So ALS sort of make more sense because of all the muscle damage. What do you think about that? And
so there's really not a clear association established at this time. We as neuromuscular specialists, we all believe that statins can really expedite or unmask an underlying neuromuscular problem. So we are very cautious about inquiring about statin use, and we try to eliminate that use. Once we diagnose patients with any neuromuscular disease, if possible, we'll try to eliminate that.
I wonder if there's a connection between, chronically elevated CPK and development of ALS later on in life. I mean, football players, I'm sure after a football game, your CK goes up tremendously, and they have a fairly high incidence relative to the general population.
Well, yeah, so that's really the question, right? So like why certain athletes are at high risk, and ALS patients tend to be slim and slender. So there's actually some suggestion that how physically fit you are, maybe it's a risk factor. We see that, and we recognize ALS in marathon runners as well. But I just don't think that there's a really good correlation or association.
So in the last couple of years, there's been a real revolution in the approach to genetic disorders. Has that changed how you order and how often you order muscle biopsy versus genetic testing?
Absolutely. So, for example, Duchenne. So, Duchenne and Becker dystrophinopathies, you don't really perform muscle biopsies on these kids anymore. So they're typically diagnosed between ages 3 and 5 directly with genetic testing. So in the setting of a child who couldn't achieve his milestones, has severe proximal weakness, and very high CK levels. I told you CK levels are profoundly high in these patients. You can proceed to genetic studies. And now there's really a good amount of studies that you can obtain also for limb-girdle muscular dystrophy. So if your suspicion is strong for and dominantly versus recessively inherited form, you can order these gene studies directly and not do all these immunohistochemical stains on the muscle anymore. Same is true for dysferlin, I think. So you can actually just directly order these genetic studies and not go through the muscle biopsy, which is another invasive and expensive study. Okay, thank you so much.
Well, I sure hope your arctic life is doing well.
Everybody's doing fine.
What?
Everybody's doing fine right now. How are you?
I'm doing tolerably well.
Been a very quiet lunch group lately. I miss your stories.
Yeah, I passed when I was going out. Actually, yesterday I passed Howard. He said y'all had a good group, but I don't know how long ago that was.
Well, he wasn't there yesterday. Maybe he ate at a different time.
Well, he wasn't talking about yesterday.
Yeah, the day before yesterday he was there, and we had 4 or 5 people.
That'd be so weird to tell things, right?
It's not what it used to be.
Well, you have a good day.
Where we just share them with each other. We set up more social media that
Yeah, most of these
well,
remember those. I mean, I can still give you the entire prep cycle.
exactly. And we
You know about that
we had someone in our class that got really upset because of a mnemonic to remember the prep cycle. So you just have to be careful.
My class too.
Yeah, but yes, those are the ones that I always remember.
30, because you remember
that's
because it is
really
30.
right. Yes.
Those Thursdays.
So we've got 4 here. We have Tremor, and then we have the guy in the hospital. It's kind of interesting because he was really kind of a basic scientist. Published a lot of high-ranking papers, literature papers. early in this country in neurology, and he went completely clinical and never wrote another paper. Grandfather did it in stroke wards. He's not really a stroke doctor, excessively compared to everything else. He just took stroke wards. And he's got a shop down in Hot Springs. He sees bread and butter neurology, but he's stroke warded, so we're using him for ARSA. And I met with him a couple of years ago to see if we were going to join an appointment. He never comes here. He doesn't do anything. He's only interested in doing the stroke thing because it pays him money. So, so I, for that, I just, why should I give him a joint appointment? He's not doing anything for us. So I kind of let that go.
I thought there must be a story about a family stroke or some dedication to the project, but
His dedication is he makes money. So I saw the announcement for the fund's new second round of funding.
Second round of funding is coming up. We need some neurology proposals.
Yeah, I would love to have.
I don't know who's who's considering a proposal this time around, but it would be one of the ideas is to encourage folks to research and stroke.
What I will do is encourage Nico and Archana and Sakiva to put together something either alone or as a consortium.
Yep.
So I don't think it was you.
I think they're all kind of independently so busy, and Archana has
renaming them, I think.